Hello friends. In this video we will discuss important points to consider while doing a pediatric cataract surgery. As surgery is done under general anesthesia, taking a superior rectus bridal suture is very helpful for positioning the eyeball. This is a case of a 3-year-old with bilateral visually significant zonular cataract. In pediatric cataract, principles of surgery are similar to adult cataract surgery with some additional points to consider. Keeping in mind the highly elastic nature of anterior capsule, getting good visualization during anterior capsulorrhexis is important. For this reason, a good staining of anterior capsule using Trypan blue for 30 to 45 seconds is necessary. After washing off the Trypan blue, forming anterior chamber using cohesive viscoelastic like Helon GV or Cohevisc helps in maintaining anterior chamber and flattening anterior capsule. Using a microrrhexis forceps or Utrata forceps helps in controlling the rhexis, which has high tendency of running to the periphery due to elastic nature of anterior capsule in pediatric cataract. In such zonular cataracts, cataract margin can be used as guide for sizing rhexis of around 4.5 to 5 mm. For better control and symmetrical sizing, it is important to re-grab the rhexis margin near the torn edges every few clock hours. Note the centripetal force applied with forceps after tangential tearing to prevent the peripheral extension of this highly elastic anterior capsule of 3-year-old. Main port entry can be done at this stage or prior to anterior vitrectomy, as after vitrectomy the globe becomes softer and entry might be little difficult. Lens material can be easily aspirated using bimanual IA cannula. Note the more sticky nature of lens material. Switching the ends of IA cannula may be needed to facilitate the lens aspiration. Once the lens aspiration is completed, viscoelastic should be injected into the anterior chamber, taking care that visco is not pushing the posterior capsule backwards. This step keeps the posterior capsule bowed anteriorly and maintaining anterior convexity in posterior capsule, which in turn makes the nicking of the posterior capsule easy. Through the opening in the posterior capsule, small amount of cohesive viscoelastic is injected in posterior segment to push the anterior hyaloid face. Opening in posterior capsule is seen clearly here. Primary posterior capsulorrhexis is a must in the patient up to the age of 7 years old to prevent posterior capsular opacification. This can be done with microrrhexis forceps before putting the IOL or with the help of vitrecker, also known as vitrectorrhexis, after putting the IOL by going behind lens. Posterior capsule is very thin and more elastic compared to anterior capsule. Aim should be to make 3 to 3.5 mm posterior capsular opening to prevent visual axis opacification. Anterior vitrectomy in pediatric cataract is a crucial procedure aimed at preventing visual axis opacification by removing anterior vitreous, which acts as scaffold for lens epithelial cell proliferation. The cut rate can be kept moderate, around 800 to 1000 cuts per minute for anterior vitrectomy and slightly lower in case of planning vitrectorrhexis for better control of managing posterior capsulotomy size. Note the vitrector is cutting anterior vitreous alongside the posterior rhexis and also beyond it 360 degrees. while near the rhexis margin and behind the capsule note the down-facing vitrector port to prevent inadvertent cutting of the rhexis. Posterior capsulorrhexis along with anterior vitrectomy helps in preventing visual axis opacification and also prevents need for secondary surgeries in younger children. In older children, beyond 8 years, posterior capsulorrhexis alone may be sufficient. Here a 5 mm anterior capsulorrhexis and 3 mm posterior capsulorrhexis can be clearly seen. After forming the anterior chamber and bag with viscoelastic, single-piece hydrophobic monofocal IOL is inserted into the capsular bag. In case of inadequate posterior capsular support, a 3-piece IOL can be inserted in sulcus with optic capture through the anterior rhexis. Due to significantly lower scleral rigidity and higher elasticity compared to adults, the corneal and scleral wounds are not usually self-sealing, and that is why it is important to suture the ports using 9/0 or 10/0 absorbable sutures. Thorough visco wash for anterior chamber and behind the IOL is necessary at the end of surgery. Side ports hydration is done. Putting a small sterile air bubble in AC helps in maintaining the anterior chamber and post-vitrectomy softer globe and also gives a clue about the post-operative inflammation if it is taking time to get absorbed. Subconjunctival antibiotic plus steroid injection is given. Thank you for watching.